The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
I'm here today because our dear colleague Meg Youngson took it upon herself to, rather than accept this invitation to speak, she thought actually walking up the glaciers and the volcanoes of Iceland was better. And I think we're nearly as cold as that, but we're probably not as much fun as that. So I'd really like to acknowledge that this is Megan's work, and Julie and I supervised her. Meg came to us and said, I'd really like to do my master's on should family be present during resuscitation. And we said, no, it's been done to death. They should be. But no one has looked at whether families should be present when we have a MET call. And Meg was an emergency nurse, and so METs didn't quite exist in that system, and so what we looked at was METs during a clinical deterioration, should family be present during clinical deterioration. This was a very large study. Meg has published 3 papers from this already, so if you Google her name, if you're interested in this, please look it up because I cannot give it justice in 15 minutes. So as I said, it's very well, family presence is very well established during resuscitation, and hopefully we all have policies that enable that. And when we hear about all the medico-legal aspects, one way to reduce a lot of angst is to have family present during a resuscitation. The epidemiology, as we know, of clinical deterioration has changed. We recognise that family are really important in many of our standards, but we don't often link those standards together, and perhaps the comprehensive care one will go some way to us not working in silos towards it. So what we wanted to do was really explore the clinicians' attitudes, their beliefs and perceptions about their own practice and how they wanted to practice in relation to having family present when an ED patient deteriorated. So the first thing we did was get a survey tool that was of family presence in ICU, and Meg set about validating that tool before we could use it. The second part was then to distribute that tool to emergency physicians and nursing staff, and then to go in and observe episodes of clinical deterioration and interview the nurses and patients' relatives afterwards. So this was quite a comprehensive study. It was carried out at a 50-bed urban ED that Julie would be able to tell you the number of presentations to a year, 70,000? 76,000, I was 6,000 out, it's probably more by now. And they had what's called a clinical instability criteria, which was pretty similar to the MET, but obviously utilises a local emergency team that was set up rather than calling on the hospital MET. And we just did simple descriptives and thematic analysis. So 176 surveys were sent out, and we were pleased with a 94.5% response rate. We had twice as many nurses as doctors, which was probably very reasonable in terms of workload representation, and we're very grateful to those people, some of you who may be in the room, who responded to that. There were many people of various levels. So when we talk about professional appointments, we're really talking about from the most junior nurse to the most senior clinicians. And this was an area of Melbourne, as many of you know, we are very multicultural, but this hospital was in a particularly multicultural area, and it's extraordinary that we were able to get 27 ethnicities actually represented in the data. And the survey actually went out to multiple EDs, not just one ED, let me add. The people who informed the study were not overly experienced. The median was 7 years of general hospital nursing medical experience and 4 years of specific emergency. The observation study was much smaller in comparison. This was we weren't really seeking to triangulate the data, but we wanted to go in and have a look and see what actually took place as a prelude to perhaps some doctoral work. And so 5 clinical observations were consented to, so you can imagine there was a great deal of difficulty to get this data. First we had to wait for people to deteriorate. We had to then ask permission to watch, and family and patient and staff. So it was quite difficult methodologically to do, And I think, we all feel slightly uncomfortable when someone's watching our practice and making observations about that. So again, we thank those who participated. I'll show you some raw data in a moment, but interestingly, here's a couple of comments. Women had a more positive attitude toward family present compared to men. Nurses had a more positive attitude to having families present compared to doctors. Australian and New Zealanders, compared to the other 25 ethnicities, had a more positive view towards having family present. Nurses with postgraduate emergency care qualifications were more comfortable and more positive about family being present, and those with more years of experience had a more positive attitude toward family presence. That tends to suggest the experience and the qualifications that perhaps we're more comfortable with our practice could defend our decisions. That's an inference, not a determination, because the question was worded about attitudes rather than... So I don't know if you can read this, and we struggle to actually make this as large as we can. So what we've done is, these are the items on the tool, and we've put the top ones with the asterisks before the gap are those that were statistically significant. So this was those between nurses with a postgraduate qualification compared to nurses without. And essentially what it says, if you read these in reverse order, is whether it was a level of agreement. So senior clinicians did not agree, or if you like, I'll go the other way, inexperienced clinicians with no qualifications thought that families would interrupt patient care, statistically more significantly than those with postgrad qualifications. That families would interfere and interrupt. Families would destroy our team communication. They would make it more difficult for the team to do their job. They would misinterpret our own activities. They wouldn't be able to voice their true feelings. The patients wouldn't, with the family present. That families would increase patient anxiety, patient stress, that it would be too traumatic for the family, that it would increase the clinician's anxiety, the clinician's stress, and the last item was, if families are not present, I make an effort to find them. And again, the experienced clinicians would make an effort to find them, whereas the inexperienced clinicians, I'm talking about experience, sorry, postgraduate qualified, would look for the family, the others simply would not. Now, sometimes that might also be about their skill level in dealing with something in an expedient way. There was no difference in their attitudes about whether families would complain, witnessing deterioration being stressful, anything about their practice, and whether they encourage or discourage, or whether there was going to be a difficulty in providing psychosocial support. The next one I'll show you is the difference between medical staff and nursing staff. So the doctors are the green there, and again you read this in reverse order. So the medical staff thought that families would impair team communication more so than nurses. They would make it more difficult for the team to do the job, and that's a global team, not just a medical team. They would misinterpret the activities of the healthcare team. They'd increase the clinician's anxiety and their own stress, and they certainly don't make an effort to go and find them. And the rest were, you can see they're fairly similar. Where there are differences, they were not statistically important. With the observations, this was actually quite detailed data, and so we actually were able to make a model despite the fact, and it was intensive qualitative data, and it was almost ethnography because she was there for so long. There were three main themes that came out that were characterised. Either the family there was no presence, there was a physical presence, or there was a therapeutic presence, and there was a difference in that. That the roles of the clinicians could either be a primary, secondary or tertiary role, and the level that they engaged families was either at a superficial or a much deeper level. And this is the model that we ended up developing. So on the left-hand side there you see the patient deteriorates, where there's no presence of anyone there at the time, and if they are there, there's sort of some level of superficial engagement where the nurses and the doctors are just doing their primary roles, just attending to the patient, taking assessments. And then as we gain an understanding of deterioration, the doctor and the nurse can take on this secondary role of involving family, involving the patient, involving the team in the whole process. And when that happens, there's a stage then obviously the team progresses to where you're then going to make therapeutic interventions. And that's where if the nurse took on this sort of tertiary role of involving the family and or the family that were present and was delivering a very therapeutic presence where the family were encouraged to be a part of it, there became a much more satisfied clinician and family and patient, and that was coined as a deep engagement. So various individuals operated within that continuum, and really that's what we observed. The interesting observation about this was that if you had the characteristics of no presence, physical presence, and the clinician having a primary role and a superficial engagement, it increased patient and family anxiety and distress. It decreased communication with the with family members and the patients and the clinicians. So there's this characteristic almost disengagement that was going on. With therapeutic presence and the role of the clinician engaging people, the family member role of comforter and supporter, deep engagement created a very warm and empathetic environment that decreased the anxiety of the family member, the patient and the clinician, and their distress, and it actually enabled greater communication between that whole team as well. Each level of family presence was characterised by the clinician's emotional response to having family present during the patient's episode, and the clinician's acceptance of including a family during the patient episode of deterioration, the clinician's actual relationship with the family, and their ability to then prioritise and manage the whole deterioration. And I wrote all of that because to remember that I wouldn't get it accurately, and I leave you to read some of that. But you can see that, again, there's this continuum, and where things turned out really well, there was a much richer and rewarding experience, and the whole resuscitation, for want of a better word, or clinical deterioration, was just managed in a much deeper way. And Meg was talking about families who were just up against the wall, completely fearful of what was going on until people actually engaged them, because of course they didn't want to get in the way. And once the nurse or the medical staff actually engaged the family, the whole dynamic changed in that room, and the patient was also more relaxed. And you know, we know our patients, particularly in a non-English speaking background, but not, I don't think statistically, we haven't proven that, but certainly it was an observation that having someone there who else could speak English and understand what was going on was enormous comfort, because they still felt, as you can imagine in an ED, people were coming running, and they're still in an undiagnosed and undifferentiated state where there's a lot of confusion and fear. So the limitations, I'd start with the tool. The tool has only now been validated in one setting, or well, in one study, so I think to revalidate that in other settings would be very useful. The study, the observations, was only carried out in a single site. As you know, it was very few observations, but in fact the data was really rich. It was a fairly short duration in the field. She was probably there for about a month, but I think if she was there for 3 or 4 months, we would get richer data. It may well be context specific. You know, this was a setting, as I said, that sees a certain, doesn't see high levels of trauma, for example. There may be quite different behaviours in a trauma setting. And I think a model like this, it would be very useful to test it in a ward setting. I don't know of any work outside of the emergency department where we're really looking at having family present during MET calls, and I think there's a lot of scope there, and I don't know that it's something we always think about. So in conclusion, there was really a very positive view towards family presence. You can see that many of our characteristics actually really affected our beliefs and attitudes and perceptions. There was an overwhelming concern for the emotional well-being of the family as well as the patient, and clearly we're primarily focused on the patient, but Meg's data really showed that we cared a great deal about family visiting at that point. And it was sort of perceived to be a day-to-day practice. No one really got that fussed about it. And I wonder whether that says more about ED than it does about those clinicians specifically. Most staff were very comfortable providing family with an appropriate level of support. And what we didn't explore was how those clinicians had developed those skills to actually be so accommodating and so welcoming and such good communicators with the family, and what the differences were between those who could do that and those that clearly did not do that or could not do that. So I'll leave it there, and I'm happy to take any questions and make any comments. Thank you.